Welcome to Series 4 of Diabetes Health Matters. My name is Dr Joan St John and I am delighted that we're back with you presenting Series 4 of Diabetes Health Matters, sponsored by Eli Lilly and Company and Menarini, although they have no input into the content of this webinar series. We're kicking off Series 4 by looking at the different types of diabetes. Did you know that there was a type 5 diabetes? Did you think you knew everything there was to know about type 1 or type 2 diabetes? Well, I think we've got some new things to share with you. We are delighted for this first part of the series. We're joined by Dr Jean Claude Katte, who is a clinical diabetes researcher who is working through the University of Exeter, as well as sharing his experience and expertise from the National Obesity Centre in the Yaoundé University in Cameroon. He has been doing some groundbreaking research, particularly in the field of the diagnosis, the types of diabetes, and particularly in type 1 diabetes. So we're kicking off this series looking at type 1 diabetes, but maybe we should have renamed it You Think You Know Everything About Type 1 Diabetes. Well, actually, there's some other things that you may not know. So we want you to stay active in the chat, ask lots and lots of questions, because I'm sure when you see the episode and hear the episode, you will have lots and lots of questions to ask. Things aren't as clear-cut as you might think. So stay active in the chat, ask lots of questions, and I'm going to now welcome Dr. Jean Claude Katte. Welcome, Jean Claude.
Thank you very much, Joan. It's a pleasure to be with you on this forum to talk about type 1 diabetes and also about the research that I've been doing within the last few years.
Give us a little hint about that groundbreaking research that you've been doing. What is so novel and new that you've discovered within the field of type 1 diabetes?
So the setting here is in Africa, and I actually led this research that started back in 2018, and with our team, we were able to find that among young people who present like type 1, like they've got type 1 diabetes, within that group in Africa, there's actually two distinct disease groups. We have a small group of young people presenting with true classical type 1 diabetes like seen anywhere else in the world, but the majority of these young people in Africa have this atypical form of diabetes. I would say, which is new because it's not type 1 when we've looked at their genetics and their immune profiles, and it's not type 2 because people who have type 2 diabetes are not insulin deficient to the point that we have seen in this in Africa in these young people, and they don't have the BMI profile that they look like type 2. And we went further to check their genetic component, whether it looks like normal type 2 diabetes, and it was different. So we think that this is actually a distinct disease category found in these children and young people in Africa.
So in these countries in Africa, you found that it's only 30% of the children and young people who would be having these autoimmune typical type of type 1 diabetes with the autoantibodies present, compared to 90% in a European, UK, US, Caucasian white population. Is that correct? So, I mean, that is quite an amazing disparity between the two, isn't it? You know, an amazing difference between the two. You said it was recognised before. Why was it not developed? Why was that recognition not developed then, would you say?
I would tell you why not really recognized before. I would tell you what what made this study different from other studies that have been conducted in Africa. So, if you go to a clinic and you take or every young person who has been given the clinical level of type 1 diabetes, and you just do these autoantibodies, because there is a mixture of disease, as I'm saying, and we've seen from my study that the majority of young people actually have this novel non-autoimmune form of diabetes. So there's kind of a dilution. So what I think is that previous studies have reported a dilution of two disease entities in Africa, and then most of the results will just come out and say that in Africa type 1 diabetes doesn't look like diabetes we see in Europe or in the US or in Asia. But in this study, what I'm saying is that there is actually two distinct groups. There is type 1 diabetes, like you would find type 1 diabetes anywhere else in the world, but there's this other group that has never been recognized. And probably we're going to talk more on this, because some of my research efforts would be to really clinically characterize this new form of diabetes and to study it in depth so that I can feed back this scientific discovery to the broader scientific community.
So looking for those autoantibodies, those antibodies that the body has formed against the insulin-producing cells in the pancreas, what did you discover within the communities living in Africa?
Yeah, before going there, I would start by what is generally known within the scientific community. And when I say that, unfortunately for us, these data come from studies in the UK, for example, or from the US, or from other high-income countries. So if we look at the normal UK population, and especially within the white population, and you do these antibodies in young people who present with diabetes, you would find that 9 out of 10 children or young people are going to have these antibodies. So this was thought to be uniform across the world, so that, young people with type 1 diabetes, the majority of them have islet 2 antibodies. So when we conducted these studies across different countries in Africa, because we had cohorts from Cameroon, from Uganda, from Tanzania, from South Africa. So when we looked at these autoantibodies, strikingly, we found that these are young people. They have been told by their doctors that they've got type 1 diabetes, but only 30%, so 3 out of 10, presented with these autoantibodies. So this was in itself, not very striking, because in the past, other researchers have said that, okay, antibodies are low. But we did other tests. So we looked at C-peptide levels, for example, and we found that these individuals generally had low C-peptide level.
Jean-Claude, just for clarification, just tell us what C-peptide is, for those who don't know.
So C-peptide, as the name indicates, it's a peptide. So it's a molecule in the body. And it's interesting to know that when the insulin-producing cells of the pancreas, when they produce or secrete insulin out of the pancreas, that insulin is secreted with C-peptide at the same time. So, but clinically, measuring insulin in the blood or in the urine can be very difficult. And so if I want to know the amount of insulin that was produced from the pancreas, I would instead test for C-peptide rather than insulin. That C-peptide molecule gives us a very strong estimate of the amount of insulin that was initially produced by the pancreas.
And I mean, it's going to be fascinating when you take this research forward to then look at the black populations within the US and the UK. I'm hoping that's going to be a step in the future.
I mean, you've touched something which we did, in a very small fashion in the paper, because with colleagues in the US, we actually looked at a very good resource in the US. It's called the Search for Diabetes in Youth Study, commonly called the Search Study. And these scientists in the US so graciously offered for us to analyze their data set in the light of what we saw in Africa. And it may interest you to find that when we looked at two ethnic groups in the US, so the blacks and the whites. So the search, I'll just talk a bit about the setting of the search. The search study is only for young people, so children less than 20 years diagnosed with diabetes in the US, no matter their ethnicity. So in the search study, you have white Caucasians or white Americans, black Americans. You've got Hispanics and other ethnic groups in there. So when we looked at the black children in the search study, we found out that there was a reversal. So 15% of these black children less than 20 years in the US actually have this novel form of diabetes as well. So meanwhile, in our African study, we found about 70%. So, but in the US, and when we went further to look at the genetics, we also saw that in these children in the US that are antibody negative, they've also got a reduced susceptibility for type 1 diabetes. So that's beginning to tell us something about, not probably only about the environment within sub-Saharan Africa, but there might be some unknown genetic component to this disease, because we are finding it in blacks out of the continent of Africa. But it will interest you to find, I would just end with this, is that when we look at the white children, they did not have any of this novel form of disease. We had 1 in 10 presenting with zero antibody, as I said previously, but their genetic profile looked exactly the same, whether they were antibody negative or positive. So just really telling us that antibody negative type 1 diabetes is different from this new form of diabetes that we've seen in blacks in Africa, but in a small proportion of blacks in the US.
Which is just mind-blowing in a way, because the more we know is the more we don't know. And here we are talking about type 1 diabetes and finding out that actually type 1 diabetes is made up of many different types in a way, almost. And we haven't even got on to type 2 and type 5 yet, but it's fascinating. So the research that you've done this and has been published this year, what would that mean for people living with type 1 diabetes who are of African Caribbean, black heritage, living in the UK? Is there anything that we can extrapolate from what your research in Africa, in those countries in Africa, and looking at the database in the US, can we extrapolate anything from that for black heritage people living within the UK?
Thank you very much, Joan. That is an important question. And as we mentioned previously, that we found that a small proportion of blacks in the US, black children in the US, had a profile that was similar to this new form of diabetes we found in Africa. And so we think that this form of diabetes, this new form of diabetes, may be present in other black heritage populations, whether in the UK or elsewhere in the world. And it may interest you to find that after the publication, or just some few weeks before the publication of this paper, because it was on a preprint server, a clinician, Sarah, she would probably watch this this video, I've forgotten where she works, but she is an NHS diabetes doctor, contacted our team in Exeter because she had an African heritage child diagnosed with diabetes at the age of 11, and they've done all the workup similarly like what we did in the paper. No antibodies, C-peptide is low. um the young child does not have genetics that look like type 1 diabetes. They went further to check in whether this child may have monogenic forms of diabetes, which we are going to talk about in other episodes. And this child did not have any of the known 57 genes, which we now know can cause monogenic or other syndromic forms of diabetes. So this is interesting. So, and we are in the UK. Interestingly as well, I've just been told by a friend of a young Nigerian ancestry girl somewhere here in Exeter with a similar profile. No antibodies, C-peptide is low, and the initial workup seems to be pointing to the fact that this young lady of about, I think, 16 years old, just diagnosed with diabetes this year, may have this novel form of diabetes. So these are just two indicators that people have contacted me for. So I believe that if we go out searching in the UK, within the Black community and the probably Afro-Caribbean community as well, we may find cases of this new form of diabetes in the UK.
I want to bring us back to get some of the basics as well. I mean, it's just, as I say, it is mind-blowing. What are the risk factors? What are the associations with type 1 diabetes?
So, when we talk of risk factors for type 1 diabetes, I think the key one is the heritability, the genetic component which goes with the disease, or as we say, associated with the disease. And we know from science, from literature, and from even from our data from Africa and some of the data sets that we've analyzed, that there are particular genetic components, and it's called the HLA. So the HLA is found within chromosome 6 in our human genome. So children who have a particular HLA type, which the common ones are called DR3, DR4, not to go into too much scientific details. So if you've got a DR3, DR4 HLA type, or HLA haplotype as we call them, then your risk for developing type 1 diabetes is quite high. It's higher than someone who does not, someone who would naturally present would not present these HLA types. And what we know, at least from the literature, is that in populations where you have higher proportions of these DR3, DR4 HLA types, you would have higher proportions of type 1 diabetes. For example, in Europeans, they have higher proportions of DR4. In Africa, we have higher proportions of DR3 instead, rather than DR4. But even at that, the proportions are far more higher in white European populations than in Black African populations. But having said that, I would say in Africa, we haven't explored all the different HLA haplotypes that may be, associated with type 1 diabetes. And so this is something that I'm also interested in looking into in the future.
There's so much to look into. So are people looking at populations to see, in a way, almost like screening now?
I'm sure you know that screening is now a very big thing, for example, in the UK, in the US. And I have a slide somewhere I picked up on LinkedIn. And they were showing on this slide screening programs all around the world. And it would interest you to find out that there were lots of screening programs for type 1 diabetes, of course, in the Americas, in Europe, in Asia, but there was no single screening program for type 1 diabetes in Africa. I'm talking about we are in 2025. And one may argue, rightly or wrongly, that probably it's the incidence of the disease in Africa is low. But, working in Africa, I'm going to say that the incidence so far has been described as being low because we haven't been looking for the disease, but also because type 1 diabetes is associated with higher rates of mortality in Africa. So probably we are missing out children who develop the disease. Why? Because they may be wrongly diagnosed as having severe malaria. They may be wrongly diagnosed as having pneumonia and other forms of severe infections, which can be associated with the development of type 1 diabetes at the onset. And so if clinicians in Africa do not recognize this, then we tend to lose many children at diagnosis of type 1 diabetes. So I think that's why the incidence is low, which leads to the fact that screening can be important in Africa as well.
We're saying new, we're saying novel. Is it too early to say that maybe it's a subtype that we haven't yet fully understood? Or is it too early to say that it is completely new? What would you say?
I would use the combination of the words which you've mentioned, a novel or new subtype. I think that would be the right way to call it. And that's how we called it in the paper, that this is a non-autoimmune insulin deficient subtype of diabetes. And until we carry out other studies to really characterize it, clinically, to a great extent, immunologically, if there are other immune contributors which we do not yet know, genetically, and also identifying some of these environmental factors which we think may be contributing to this disease. I think for now we're going to call it non-autoimmune insulin deficient diabetes subtype.
Thank you so much. I mean, honestly, it's almost like the more we know, the more we don't know. So whether it's about type 1 diabetes and perhaps these subtypes that you want to talk about, whether it's perhaps the research of Dr. Katte, if we haven't covered it, you stay active in the chat, you ask us the questions, and we will do our best to address that. I'm going to ask you a few quick fire questions because, as I say, there's so much to unpick in terms of type 1 diabetes. Now, one of the common misconceptions that I have encountered is that people will feel that if you go on insulin, you must be living with type 1 diabetes. Do you want to dispel, because I'm going to call it a myth, I'm going to call it out. Do you want to dispel that myth for us?
Yes, it is actually a myth. So, we know that we have a huge baggage of different treatment modalities for diabetes, for all forms of diabetes. And for those who have been following right from the onset, and we know, we said from the onset that it is an autoimmune condition where the body produces autoantibodies that destroy the insulin-producing cells in the pancreas. So it means that once these cells are destroyed, the body no longer has the capacity to produce insulin on its own. So what do? We have to replace insulin inside the body. So it's actually like a replacement therapy. So an insulin, we know that there are different forms of insulin in development now in this day and age, but the most common and widely accepted and well-researched form is the insulin that we inject, through the skin into our body. And so that's what we need for type 1 diabetes. That's true. There's no other treatment. But insulin can also be used for other forms of diabetes, and of course, clinicians will decide at what point to use insulin, either because, the blood sugar is not well controlled, or maybe someone has to go to surgery. And if you have surgery, for example, you may not be required to take, oral, to eat or take oral tablets, or for some other reasons, insulin can be prescribed, even for people who do not have type 1 diabetes. But for type 1 diabetes, insulin is the mainstay of treatment.
Okay, thank you. So if your family member, first degree relative, is living with type 1 diabetes, it increases your risk of developing type 1, type 2, or other types of diabetes.
If your first degree relative is living with type 1 diabetes, obviously it increases your risk for developing type 1 diabetes as well. If your mom had type 1 diabetes, or your dad had type 1 diabetes, while you were in the womb, for example, just want to talk about intrauterine exposures and risk as well. It increases your risk for developing type 1 diabetes. Now, whether it was the mom that had type 1 diabetes or the dad, the risk might be different. I don't want to go into that. There's still a lot of research coming through that point. And there's something else I would say which it's a bit controversial at times, is that obesity also can increase your risk for type 1 diabetes, or I would say precipitate someone who is already at risk to developing type 1 diabetes. So obesity is not only a risk for type 2 diabetes, can also be a risk for type 1 diabetes due to the fact that it precipitates the person who was supposed to develop type 1 diabetes develops type 1 diabetes more rapidly.
And what about its association with other autoimmune conditions? Type 1 diabetes association with other autoimmune conditions?
Yes, so type 1 diabetes can be associated with other autoimmune conditions. Key ones, for example, are thyroid disease or hypothyroidism, for example, autoimmune hypothyroidism. It can be associated with celiac disease, which I guess is very common as well in Europe. And other forms of vitiligo, which affects the skin discoloration, for example, and lots of other autoimmune conditions that we can think of, which is why some international bodies do recommend screening for other forms of autoimmune disease for people who have already developed type 1 diabetes.
So, and you very succinctly said previously about how the body's need for insulin, because those insulin producing cells are destroyed by the autoantibodies. So insulin is the treatment that would be needed if you're living with type 1 diabetes, but there can be other treatments that you would need in addition, but insulin is the critical treatment that you would need.
Absolutely. Insulin is the hallmark, is the mainstay for treatment. And we commonly have people living with this disease come back to us in the clinic and say, but can I not just get off this insulin for a couple of months and just try tablets maybe to see if tablets may work? And then then we have to go over the process, and it's a difficult thing. I guess you can imagine injecting yourself for the rest of your life with insulin, and which I would say brings us to something that we probably, I would say, unfortunately experience in Africa, for those of us who work in Africa, where of course you would know insulin is still an issue in terms of insulin access. Insulin is expensive, and many African countries do not cover insulin either through universal health coverage or either through private insurance scheme. And so people who develop the disease may not necessarily have money to buy insulin always. And so at times some families have to ration insulin over a period of time. And when I say ration, I mean taking smaller doses of insulin so that it doesn't finish up rapidly. And you can imagine the after effect of that, diabetes not being well controlled and the development of all the complications, ketoacidosis that we see. And so, yes, there is still this issue of insulin access, which obviously we don't experience, and those of you clinically active in the UK probably may not experience with now all the technology, driving insulin, but for young people living in countries and parts of Africa, it's really still a hurdle getting insulin and managing insulin properly.
I mean, that's such a salutary statement. I don't want us to end on that, but it's something that we should be so aware of, because here we have so much choice. We have so many different types of insulin, and so much insulin availability, that we have to be aware that that is not the case for globally. That people can struggle to actually access something that we would say as basic as insulin. I want to ask you and finish this episode on what are your hopes for the future in terms of type 1 diabetes. You've got lots of ideas for your research, and where are you hoping that research is going to take us?
Yes. In terms of research, try and find out if we have cases of this new form of diabetes in blacks or people of black heritage in the UK and in other parts of the world. Because remember, I mentioned that we found about 15% in young black Americans in the US. And why is it important? Because if we uncover that this is environmental, that there is some environmental determinant, it means we can actually prevent the onset of this diabetes by actually intervening, by controlling that environmental factor. If it's a virus, it means there are probably vaccines that can be developed for that particular viral material. If something coming from the water or from heavy metals in the earth in Africa or from food pesticides, it means we can write policies around the regulation of these different environmental contaminants. So that's one aspect of what I will be doing immediately. And the other aspect that is close to my heart is around just the general treatment control of type 1 diabetes and reducing mortality. So that's another aspect of my research that is very close, which I would be focusing on within short and medium term.
Dr. Jean Claude Katte, that's absolutely amazing. I know there's going to be lots and lots and lots of questions, so I think we'll round it up there, and we'll give time for people to ask all their questions about type 1 diabetes. Thank you so much. Thank you so much for sharing your research with us and for giving us all that information.
Thank you very much, and thank you to you and the team for having me on this episode of Diabetes Health Matters. Thank you very much.
Thank you, Joan. Thank you, Dr. Katte, for this introduction to the topic. We're now moving on to the Q&A segment of our episode today. My name is Adeyileka-Tracz, and I'm a director at Diabetes Africa. We have already received a lot of questions during the registration process and also during the episode. So I will start with these questions, but please don't hesitate to add questions in the chat, and we will do our best to pick them up. I am just checking if Dr. Katte is still with us. Dr. Katte, are you there?
I'm there. Well, just 1 minute. Yes, I'm with you. I haven't run away, Greg.
Okay, excellent. The first question really is about the impact or the consequences of what you have found in your research. What can we say about treatment and diagnosis of type 1 diabetes, or what is the impact of the of research on these two aspects? Is it too early to say?
Um, mm, well, too early to say in some ways, but not. I would say that I think I would answer that question, and it would logically answer some other questions that I've seen in the chat. Um, so with regards to the way the disease presents, it presents almost exactly the same as true autoimmune type 1 diabetes, if you look at the classical features. Um, I think one of the limitations of the study, which we pointed out clearly in the paper, was that we had people who presented with varying durations of diabetes. And we know that some of these autoimmune markers can fall off, with extended diabetes duration. Um, and so going forward, we would want to study individuals from diabetes onset or really close, because we think at diabetes onset, we would be able to disentangle the autoimmune and the non-autoimmune type and look whether, there are significant clinical features that can distinguish between the two disease types. Now, it's to answer the question directly with regards to treatment, both types are insulin deficient, which is why it's important and separates this new phenotype from all the other types of diabetes, like type 2 and the other types that we will talk about. So if they are insulin deficient, it means they need insulin treatment as well, just like the individuals having true autoimmune type 1 diabetes. But what we can add to that is we do not know if other cells of the pancreas are involved, are also destroyed. That might mean that they may need additional therapy or additional replacement therapy. We don't yet know that at the moment, but it's something that I'll be studying subsequently.
Thank you, Jean-Claude. Shukrat in the chat just commented, I think this research is important for getting the correct diagnosis, as many people are diagnosed as type 2 because they test negative for islet autoantibodies. Do you agree with this?
Yes, I think there is a fine line, and that's why I think, you know, especially in young people, there is a blurry line between, type 1 and type 2, but we can use clinical features to guide us, like obesity, family history of diabetes. Those features can guide us. But what should drive treatment, especially at onset, is insulin deficiency. So if you have someone who has very low endogenous insulin secretion, which you can measure by doing C-peptide, as I said in the presentation, then you have to, put that person on insulin therapy. So antibodies, they are good at diagnosis to tell us whether we have type 1 or we don't have type 1. That's true. But also remember that even in white European populations, 10% do not present with antibodies at diabetes onset. So that should always be at the back of our mind.
And can I just add to that? Thank you very much for that, Jean Claude, and thank you very much for a really excellent episode as well. And one of the things that we said during the episode was that the more you know, the more you find you don't know, and you use that word blurred lines, and I think that is so illustrative of what we're dealing with here, because you, as a clinician, have to be constantly on your guard, aware of what type of diabetes the person in front of you may have. It may appear clear cut at the beginning, but those lines are blurred, and sometimes you find that you're questioning, actually, is that initial diagnosis correct? And I think keeping that open mind always is just so important.
Absolutely. I mean, there is an excellent resource, I would say, on the University of Exeter diabetes website, which you can use to distinguish between type 1 and type 2 using clinical features. Just to say that those resources were built with data generated mostly in the UK and mostly among, white European people with diabetes, and so may not uh, particularly be accurate in non-white populations, but there's that resources available online free of charge.
Thank you.
Thank you, Jean-Claude. There are a lot of questions about the different types of diabetes, and I want to clarify here that the way that we have structured the first 3 episodes of Diabetes Health Matters this season is that we are taking, this is such a vast topic that we are addressing mainly type 1 today. In a couple of weeks, we will have type 2 and questions around diagnosis of type 2 and other subtypes, and then we'll have type 3, 4, 5 also. So even though there are questions tonight about other types, we will haven't try keep it to type 1. However, I will ask you a couple of questions that are somehow related, Jean-Claude. First one is, what is type 1.5? And potentially related, one of the participants was talking about a young person who had been diagnosed with type 1 initially and turned out to be a type 2. Can you tell us a bit more about what may have happened there?
All right. Let's start with type 1.5. If you go back and look at some of the classifications of type 1 diabetes and I would say diabetes in general, and how it has changed from the 80s to 2025. The terminology has gone through lots of changes, and type 1.5 was first talked about in classifications that looked at type 1 diabetes being type 1, and then type 1A, and then type 1B. At some form, it was called idiopathic type 1 diabetes. Some people called it type 1.5 diabetes. But that group, which was called 1B, 1.5, was actually, looking back at the literature, was actually a mixture of different disease groups, especially was mainly ketosis-prone diabetes at the time, if we look at the literature. So we know now that type 1 diabetes, it's really clear. It's an insulin deficient disease caused by autoimmune destruction of the pancreas. So that's really clear. And now we are also showing that we can also have insulin deficient diabetes, but not as a result of that autoimmune destruction of the pancreas, which is the focus of my study.
Yes, and the second question.
The second question, someone diagnosed as having type 1 and then later discovered to be having type 2, and the other way around as well is very common. So as clinicians, right, we were taught from medical school, if you're young, for example, if you're 20, below 30 years, and you've got low BMI, let's say BMI of about 19 and 20, you present with ketosis, then you should have type 1 diabetes. But now we know that's not the case, because you have young people who can present with type 2 diabetes, but being lean, and then, have low BMI, and they can also present with ketosis from onset, hence the term that we would probably talk about in other episodes, ketosis-prone diabetes. So yes, it is good to have a working diagnosis from onset. Antibodies can help you at diagnosis to make the difference between type 1 and type 2. I precise well at diagnosis. C-peptide will not really help you at diagnosis to make the difference, because people with type 1 diabetes can have high C-peptide levels at diabetes diagnosis. But C-peptide can help you guide your treatment. But after, for example, 3, 4, or 5 years, C-peptide then becomes an important biomarker to tell you whether that person needs insulin or not, or whether you should continue treating that person as having type 2 diabetes. So those are some of the ways that you can use both antibodies and C-peptide to guide your diagnosis, but also to guide your therapeutics.
Thank you, Jean-Claude. Among the questions we had were some just two words. Someone put two words: type 1, well, two blocks of words: type 1 diabetes and prevention. Can you tell us a bit about this? Because you said that the type 1 diabetes can appear later in life. Is there anything? Is there anything that can be done to slow down the or to postpone the onset of type 1 diabetes?
So hence the need for screening, which is something currently being widely implemented through different programs in the UK, whether like the ELSA project for children or the TIDRA project for adults. And I know there are other screening programs being rolled out because for example, if during screening it's found that you have any of the antibodies or any of the islet O2 antibodies, then it means your risk for developing type 1 diabetes is very high. And then obviously we now know there is a drug that can be used to slow down the progression to type 1 diabetes, teplizumab, which has just been recently approved as well in the UK. And I know it's currently already being used in the US. So that's something that can be used to slow down the progression. But apart from that, there is really nothing you can do per se to prevent someone from having type 1 diabetes. So knowing your risk, maybe by doing islet O2 antibodies can be important. Knowing your risk by doing markers of your genetic susceptibility, whether you have the HLA DR3 or DR4, or the genetic risk score, which is just a simple score, can help, guide you whether you are at increased risk for type 1 diabetes or not.
Can I just add something as well, Greg, before you move on? The unfortunate fact is that within the UK, even within this high resource setting, a lot of people living with type 1 diabetes will present in DKA, in diabetic ketoacidosis, which is a life-threatening condition. And hopefully one of the other effects of screening will be that this is lessened, that people aren't presenting as an emergency case to hospital and in a life-threatening condition when they're first diagnosed with type 1 diabetes. So I think that is another important aspect of what screening is hoping to achieve.
Absolutely, Joan.
Thank you, John, for this. It's very important to do this. Elia from Tanzania is asking, in an African context, without antibody and genetic testing, how can we distinguish the new non-autoimmune subtype and the classical one?
That's a very good question, Elia, and quite difficult to do without antibodies and genetic testing. I've currently done a survey across different diabetes clinics in sub-Saharan Africa, and just about 28% of different diabetes clinics and hospitals have access to both C-peptide and antibody testing. So only 28% across sub-Saharan African countries. There were, I think, 35 different countries that participated in the survey. So your question is important because we do not have access to these biomarkers, which we call classification biomarkers for diabetes. How then can we distinguish this type? And not only this new subtype, how can we distinguish type 1 from monogenic forms of diabetes, distinguish from early onset type 2 diabetes, from ketosis-prone diabetes? So it's an important question, and it's a difficult one at the moment, which is why the next study, which we would be setting up in January, and we are already thinking about this. And the aim would be to really study these forms of diabetes from diabetes onset so that we can identify clear clinical markers that can help us distinguish even without the use of these classification biomarkers. Hopefully, we would be able to find that some clinical features are predominant, and then we would be able to study whether we can have thresholds. For example, say at a BMI of 21.5 in Africans, then you should start, think that there might be a difference between type 1 and this new form of diabetes or something like that. I don't know, skin fold or something like that. I don't know what we are going to find. So, but we have a study in place that will look into that.
Thank you, Jean-Claude. We'll take a couple more questions. Before that, to everyone in the room, can I ask for your attention and participation in the polls that we are running? We'd like to know more about you and who you are and what you found about this session. So if you are on your desktops, a survey, a quiz should pop up on your screen. If you are on your phones, you may have to swipe to come to the poll section. So we are asking about your background. That's the first question. Thank you, and you are voting. So very very kind of you to provide this information. And the second question is about. I'm going to share the results. And the second question that we have is about this episode particularly, because we'll take two more questions, but we would like to know if you've learned anything during the event that we can use in your practice or in your daily life if you are living with diabetes. We'll give you a few more seconds to vote. I see that the numbers are going up. About half of the people are voting. You can vote on your phone if you look for the poll section. Otherwise, if you're on your desktop, it should pop up on your screen. Thank you. Thank you. Thank you. And in the meantime, Jean-Claude, could you tell us? Someone asked about the management of type 1 diabetes beyond medication and insulin. Is there what can you say about that element?
That is a really good question, because it's not all about therapeutics per se, pharmacological therapeutics. I would say in type 1 diabetes, we know that there is a huge component which is educational, knowing about the disease, knowing about what to eat, knowing how to administer insulin. For high-income countries, knowing how to manipulate and use all the technologies that are available. What about family support? We know is very important for type 1 diabetes care. What about physical activity? Can be very important for type 1 diabetes care. So yes, there is a huge non-pharmacological aspect for type 1 diabetes care. There are many structured diabetes educational programs, for example, in high-income countries that we know about, Betil, and some of the others for people who are into type 1 diabetes care in the UK. And unfortunately, we do not have structured diabetes programs in most of our African countries. The classical example in Cameroon, for example, where I practice mainly, if you move from one clinic to another, you may hear complete mixed messaging with regards to what you have to do for adequate type 1 diabetes care. And so that's an aspect that if someone is interested in working with us to develop educational programs for type 1 diabetes care in Africa, please kindly get to me, and it will be something important, very important to do, because with something as important as education, which is I would say less expensive, we can have a very huge impact in the lives of those living with type 1 diabetes.
Thank you, John. Yeah, please
Greg,
go ahead,
can I also
John.
add, as a primary care and community healthcare professional, I think it's really important that people with living with type 1 diabetes also have their what we call the 9 key care processes, because that's available within the UK. So things like the retinal screening, things like, because quite often people living with type 1 diabetes will be having their care from a hospital or a community setting and wouldn't necessarily go and see their primary care healthcare practitioner, but they should, at least on an annual basis, have what we call these 9 key care processes: blood pressure checks, weight, height, urine checks, retinal screening, that sort of thing, cholesterol checks. I know that's done at the hospital as well, but it's really important to get foot checks and the retinal screening and those 9 key care processes done through your primary healthcare practitioner as well.
Thank you, Joan. One point on to follow up with Jean-Claude on exercise. Is it true that aerobic and resistance training can improve insulin sensitivity for people living with type 1 diabetes?
Absolutely.
Question to
Absolutely.
you, John.
Yeah, very important. It's true. The direct answer to that question is yes. Exercise will improve insulin sensitivity. Obviously, through you have glucose-related mechanisms, but also non-glucose-related mechanisms, because there are different types of insulin receptors on the cells, and some of them are very sensitive to exercise and would enhance insulin secretion, and therefore help your blood glucose levels. And so exercise will increase insulin sensitivity and help. But exercise in type 1 diabetes has to be controlled, because there's also the risk for for the person developing hypoglycemia. So it's just important to be aware.
Thank you, Joan. Did you want to add to this point?
Well, we were talking about blurred lines, and I don't want to open something now towards the end of the episode. But there is an emerging, how shall I put it, appearance of people who are living with type 1 diabetes who are also living with obesity or overweight. And in those circumstances, of course, again, because the obesity or being living with overweight can produce insulin resistance, so exercise can be helpful in that. But I don't want to blur the lines further at this stage of the episode, so I'm going to leave it just like that.
Thank you very much, Joan. Thank you, Jean-Claude. Before I give you the floor for the last thoughts, I need to share with everyone some dates. So if you've got a pen and paper, or if you have a really good memory, please remember on the 16th of October, so in a couple of weeks, we will be meeting again with Jean-Claude and Dr. Joan St John to speak about type 2 diabetes. And on the 30th of October, we'll turn our attention to type 3, 4, 5. So if you've enjoyed the discussion today, join us again later this month, because this is your forum to ask and learn, and please share information about these events to other people who you think would be interested and would benefit from being in the room. Dr. Joan St John often says, each one teach one. And finally, if you are a healthcare professional living in the UK, working in the UK, please come and join us on the 26th of November. Our Diabetes Africa UK forum is taking place in London. You've seen a link in the chat. I will repost it. Join us on the 26th of November with like-minded people who want to make a difference. Now, the floor to you, Jean-Claude, first, and then we'll close with Dr. Joan St John. Thoughts or things that you would have liked to add to the discussion today?
Really, I think we've done, I would say, to the force around the topic of type 1 diabetes today. The classical type, of course, that's what everyone knows, and then this novel type, which we've just described in Africans living in Africa. And I would just end by saying thank you to everyone who has joined this call and have participated in one way or the other, and all the questions. And as you can see, there's still a lot to be done in this area. And I'm looking, and I'll be working in this topic, and hopefully there are other people in this forum that are interested in joining me in this effort. And so get in touch. That's all I would say. Thank you very much.
So I would like to say a massive, huge, mega thank you to Dr. Jean Claude Katte for an amazing episode, and more to come. As Greg said, I'm going to call you Mr. Diabetes Africa now, Greg. Mr. Diabetes Africa said the next sessions will be in 2 weeks' time, when we'll be looking at type 2 diabetes. And like this episode, you may think you know all there is to know about type 1 diabetes, but I'm sure you've discovered some things tonight which you weren't aware of before. And it will be the same when we talk about type 2 diabetes, and then 2 weeks later when we talk about type 3, 4, and 5. So, Dr. Jean Claude Katte, amazing. Thank you so much for sharing your expertise, your research, your knowledge with around this topic with us. I think all of us have been inspired by that. Mr. Diabetes Africa, Greg, it's great to see you, and you did an amazing job. The Diabetes Africa team always produce these webinars so professionally, and we're so grateful. And let me tell you, if I'm not breaking any confidence, that the team is expanding. So I'll just leave it at that, the Diabetes Africa team. So please stay tuned. Join us again in 2 weeks' time. Thank you all for joining, because we learn together. We feel this is a novel way of learning. It's a hybrid of healthcare professionals, people living with the conditions, their family members, and you're all so important to us. And together we'll learn and hopefully improve the situation for people who are living with different forms of diabetes. Remember, those lines are blurred. So I'm going to leave it there and hope to see you in 2 weeks' time. Thank you so much.